You are called to help resuscitate an infant with severe symptomatic bradycardia associated with respiratory distress. The bradycardia persists despite establishment of an effective airway, oxygenation, and ventilation. There is no heart block present. Which of the following is the first drug you should administer? A. Atropine. B. Dopamine. C. Adenosine. D. Epinephrine. The correct answer is D. Administer epinephrine for symptomatic bradycardia caused by respiratory distress in pediatric populations. Atropine should be administered if the primary cause of bradycardia is due to a suspected heart block, such as with adult populations. Number 2. Which of the following statements about the effects of epinephrine during attempted resuscitation is true? A. Epinephrine decreases peripheral vascular resistance and reduces myocardial afterload so that ventricular contractions are more effective. B. Epinephrine improves coronary artery perfusion pressure and stimulates spontaneous contractions when asystole is present. C. Epinephrine is contraindicated in ventricular fibrillation because it increases myocardial irritability. D. Epinephrine decreases myocardial oxygen consumption. The correct answer is B. Epinephrine improves coronary artery perfusion pressure and stimulates spontaneous contractions when asystole is present. Number 3. General assessment of a 2-year-old female reveals her to be alert with mild breathing difficulty during inspiration. On primary assessment, she makes high-pitched inspiratory sounds, mild stridor, when agitated. Her oxygen level is 92% on room air. Lung auscultation reveals transmitted upper airway sounds with adequate distal breath sounds bilaterally. Which of the following is the most appropriate initial therapy intervention for this child? A. Perform immediate endotracheal intubation. B. Administer an IV dose of dexamethasone. C. Nebulize 2.5 mg of albuterol. D. Administer humidified supplementary oxygen as tolerated and continue evaluation. The correct answer is D. Administer humidified supplementary oxygen as tolerated for suspected croup, mild stridor, and continue to evaluate. Number 4. Which of the following most reliably delivers a high concentration of inspired oxygen in a toddler or older child? A. Nasal device with 4 liters per minute of oxygen flow. B. Simple oxygen mask with 15 liter per minute of oxygen flow. C. Non-rebreathing face mask with 12 liters per minute of oxygen flow. D. Face tent with 15 liters per minute of oxygen flow. The correct answer is C. A non-rebreathing face mask with 10 or more liters per minute of oxygen flow delivers the highest concentration of inspired oxygen. Number 5. Which of the following statements about endotracheal drug administration is true? A. Endotracheal drug administration is the preferred route of drug administration during resuscitation because it results in predictable drug levels and drug effects. B. Endotracheal doses of resuscitation drugs in children have been well established and are supported by evidence from clinical trials. C. Intraosseous and endotracheal drug administration is just as effective as intravenous drug administration. D. Endotracheal drug administration is the least desirable route of administration because this route results in unpredictable drug levels and effects. The correct answer is D. Endotracheal drug administration is the least desirable route of administration because this route results in unpredictable drug levels and effects. Number 6. Which of the following statements most accurately reflects the PALS recommendations for the use of magnesium sulfate in the treatment of cardiac arrest? A. Magnesium sulfate is indicated for ventricular fibrillation refractory to repeated shocks and amiodarone or lidocaine. B. Routine use of magnesium sulfate is indicated for shock refractory monomorphic ventricular tachycardia. C. Magnesium sulfate is indicated for torsades de pointes or suspected hypomagnesemia. D. Magnesium sulfate is contraindicated and should not be used. The correct answer is C. Magnesium sulfate is indicated for torsades de pointes, also referred to as polymorphic ventricular tachycardia, or suspected hypomagnesemia. Number 7. You enter a room to perform a general assessment of a previously stable 10-year-old male and find him unresponsive and apneic. A code is called and bag mask ventilation is performed with 100% oxygen. The cardiac monitor shows a wide complex tachycardia. The boy has no detectable pulses. You deliver an unsynchronized shock with 2 joules per kilogram and resume immediate CPR beginning with compressions. A team member had established IO access, so you give a dose of epinephrine. At the next rhythm check, persistent ventricular fibrillation is present. You administer a 4 joules per kilogram shock and resume CPR. Based on the PALS pulseless arrest algorithm, what is the next drug to administer when CPR is restarted? A. Epinephrine. B. Atropine. C. Amiodarone. D. Magnesium sulfate. The correct answer is C. The next drug in the PALS cardiac arrest algorithm is amiodarone 5 mg per kilogram. Number 8. Parents of a 1-year-old female phoned the emergency response system when they picked up their daughter from the babysitter. Paramedics perform a general assessment revealing an obtunded infant with irregular breathing, bruises over the abdomen, abdominal distension, and cyanosis. Assisted bag mask ventilation with 100% oxygen is initiated. The heart rate is 36 per minute, peripheral pulses cannot be palpated, and central pulses are barely palpable. Chest compressions are started with a 15:2 compression to ventilation ratio. In the emergency department, the infant is intubated and ventilated with 100% oxygen, and IV access is established. The heart rate is now up to 150 beats minute, but there are weak central pulses and no distal pulses. Systolic blood pressure is 74. Of the following, which would be most useful in management of this infant? A. Epinephrine 0.01 mg per kilogram. B. Rapid bolus of 20 ml per kilogram of isotonic fluid. C. Atropine 0.02 mg per kilogram. D. Synchronized cardioversion. The correct answer is B. Administer a rapid bolus of 20 ml per kilogram of isotonic fluid. Refer to the hypovolemic shock algorithm for additional information. Number 9. Which of the following statements about calcium is true? A. Routine administration of calcium is not indicated during cardiac arrest. B. The recommended dose is 1 to 2 mg per kilogram of calcium chloride. C. Calcium chloride 10% has the same bioavailability of elemental calcium as calcium gluconate in critically ill children. D. Indications for administration of calcium include hypercalcemia, hypokalemia, and hypomagnesemia. The correct answer is A. Routine administration of calcium is not indicated during cardiac arrest. Number 10. An infant with a history of vomiting and diarrhea arrives by ambulance. During your primary assessment, the infant responds only to painful stimulation. The upper airway is patent. The respiratory rate is 40 with good bilateral breath sounds, and 100% oxygen is being administered. The infant has cool extremities, weak pulses, and a capillary refill time of more than 5 seconds. The infant's systolic blood pressure is 85, and bedside glucose level is 30. Which of the following is the most appropriate treatment to provide for this infant? A. Establish IV access and administer 20 ml per kilogram of dextrose over 15 minutes. B. Establish IV access and administer 20 ml per kilogram of lactated Ringer's solution over 60 minutes. C. Establish IV access, administer 20 ml per kilogram of isotonic crystalloid over 10 to 20 minutes, and simultaneously administer 25% dextrose mixed in water at 2 to 4 ml per kilogram in a separate infusion. The correct answer is C. Establish IV access, administer 20 ml per kilogram of isotonic crystalloid over 10 to 20 minutes, and simultaneously administer 25% dextrose mixed in water at 2 to 4 ml per kilogram in a separate infusion. Reassess the blood sugar and monitor for signs of fluid overload. Number 11. General assessment of a 9-year-old male with increased work of breathing. Reveals the boy to be agitated and leaning forward on the bed with obvious respiratory distress. You administer 100% oxygen by non-rebreathing mask. The patient is speaking in short phrases and tells you that he has asthma but does not carry an inhaler. He has nasal flaring, severe suprasternal and intercostal retractions, and decreased air movement with prolonged expiratory time and wheezing. His oxygen level is 92% on a non-rebreathing mask. What is the next medical therapy to provide to this patient? A. Adenosine 0.1 mg per kilogram. B. Amiodarone 5 mg per kilogram. C. Albuterol by nebulization. D. Procainamide 15 mg per kilogram. The correct answer is C. Administer albuterol by nebulization. Number 12. An 8-month-old male is brought to the emergency department for evaluation of severe diarrhea and dehydration. In the ED, the child becomes unresponsive and pulseless. You shout for help and start CPR at a compression rate of 100 per minute and a compression-to-ventilation ratio of 30:2. Another provider arrives, at which point you switch to 2 rescuer CPR with a compression-to-ventilation ratio of 15:2. The cardiac monitor shows ventricular fibrillation. Of the following choices for management, which would be most appropriate to give next? A. Defibrillation 2 joules per kilogram. B. Normal saline 20 ml per kilogram IV rapidly. C. High-dose epinephrine, 0.1 mg per kilogram. D. Amiodarone 5 mg per kilogram. The correct answer is A. Administer a shock at 2 joules per kilogram. Number 13. General assessment of a 10-month-old male in the emergency department reveals a lethargic pale infant with slow respirations. You begin assisted ventilation with a bag mask device using 100% oxygen. On primary assessment, heart rate is 38. Central pulses are weak but distal pulses cannot be palpated. Systolic blood pressure is 60. And capillary refill is 4 seconds. During your assessment, a colleague places the child on a cardiac monitor, and you observe a bradycardic rhythm. The rhythm remains unchanged despite ventilation with 100% oxygen. What are your next management steps? A. Prepare for synchronized cardioversion. B. Start chest compressions. C. Start chest compressions and give epinephrine 0.01 mg per kilogram. D. Administer 20 ml per kilogram of isotonic crystalloid. The correct answer is C. If a pediatric patient continues to show signs of poor perfusion after oxygenation therapy and the heart rate decreases under 60 beats per minute, start chest compressions and give epinephrine 0.01 mg per kilogram IV or IO. Number 14. A 3-year-old unresponsive, apneic child is brought to the emergency department. Emergency personnel report that the child became unresponsive as they arrived at the hospital. The child is receiving CPR, including bag mask ventilation with 100% oxygen and chest compressions at a rate of 100 per minute. Compressions and ventilations are being coordinated at a ratio of 15:2. You confirm that apnea is present and that ventilation is producing bilateral breath sounds and chest expansion, while a colleague confirms absent pulses. Cardiac monitor shows ventricular tachycardia. A biphasic manual defibrillator is present. You quickly use the crown heel length of the child on a length-based, color-coded resuscitation tape to estimate the approximate weight as 15 kilograms. Which of the following therapies is most appropriate for this child at this time? A. Establish IV access and administer amiodarone 5 mg per kilogram. B. Establish IV access and administer lidocaine 1 mg per kilogram. C. Attempt defibrillation at 30 joules, then resume CPR beginning with chest compressions. D. Establish IV access and administer epinephrine 0.01 mg per kilogram. The correct answer is C. Shock or defibrillate at 30 joules. Then resume CPR beginning with compressions. Number 15. General assessment of a 10-year-old male shows him to be unresponsive. You shout for help, check breathing, find he is apneic, and give 2 breaths. After finding that he is pulseless, you begin cycles of compressions and ventilations with a compression rate of 100 per minute and compression to ventilation ratio of 30:2. A colleague arrives and places the child on a cardiac monitor, revealing ventricular fibrillation. The two of you attempt defibrillation at 2 joules per kilogram and give 2 minutes of CPR. The rhythm persists at the second rhythm check, at which point you attempt defibrillation using 4 joules per kilogram. A third colleague establishes IO access and administers 1 dose of epinephrine 0.01 mg per kilogram during the compressions following the second shock. If the ventricular fibrillation persists after 2 minutes of CPR, what is the next drug dose to administer? A. Epinephrine 0.1 mg per kilogram. B. Adenosine 0.1 mg per kilogram. C. Amiodarone 5 mg per kilogram. D. Atropine 0.02 mg per kilogram. The correct answer is C. Amiodarone 5 mg per kilogram IV or IO is the next drug to be administered. Number 16. A 1-year-old male is brought to the emergency department for evaluation of poor feeding, fussiness, and sweating. On general assessment he is lethargic but arousable and has labored breathing and a dusky color. Primary assessment reveals a respiratory rate of 68 breaths per minute. The heart rate is 300 per minute, systolic blood pressure is 70, capillary refill is 6 seconds, oxygen level is 85% in room air with good bilateral breath sounds. You administer high-flow oxygen and place the child on a cardiac monitor. You see a fast narrow complex rhythm with little beat-to-beat variability. Secondary assessment reveals no history of congenital heart disease. Intravenous access has been established. Which of the following therapies is most appropriate for this infant? A. Make an appointment with a pediatric cardiologist for later in the week. B. Adenosine 0.1 mg per kilogram IV rapidly. If adenosine is not immediately available, perform synchronized cardioversion. C. Perform immediate defibrillation without waiting for IV access. D. Establish IV access and administer a fluid bolus of 20 ml per kilogram of isotonic crystalloid. The correct answer is B. Administer adenosine 0.1 mg per kilogram IV rapidly. If adenosine is not immediately available, perform synchronized cardioversion. Refer to the PALS Tachycardia with a pulse algorithm for additional information. Number 17. A child becomes unresponsive in the emergency department and is not breathing. You provide ventilation with 100% oxygen. You are uncertain if a faint pulse is present. What is your next action? A. Begin high-quality chest compressions with ventilations. B. Begin transcutaneous pacing. C. Start an IV and give atropine 0.01 mg per kilogram. D. Start an IV and give epinephrine 0.01 mg per kilogram. The correct answer is A. Begin high-quality chest compressions with ventilations. Number 18. You are preparing to use a manual defibrillator and paddles in the pediatric setting. When would it be most appropriate to use the smaller, pediatric-sized paddles for shock delivery? A. To attempt synchronized cardioversion but not defibrillation. B. If the patient weighs less than approximately 25 kilograms or is less than 8 years of age. C. If the patient weighs less than approximately 10 kilograms or is less than 1 year of age. D. Whenever you can compress the victim's chest using only the heel of one hand. The correct answer is C. if the patient weighs less than approximately 10 kg or is less than 1 year of age. Number 19. A 7-year-old boy is found unresponsive, apneic, and pulseless. CPR is ongoing. The child is intubated and vascular access is established. The heart monitor reveals an organized rhythm, but a pulse check reveals no palpable pulses. Effective ventilations and compressions are resumed, and an initial IV dose of epinephrine is administered. Which of the following therapies should you perform next? A. Attempt to identify and treat reversible causes, using the H's and T's as a memory aid. B. Attempt defibrillation at 4 joules per kilogram. C. Administer epinephrine 0.1 mg per kilogram. D. Administer synchronized cardioversion at 1 joules per kilogram. The correct answer is A. Attempt to identify and treat reversible causes, using the H's and T's as a memory aid. Number 20. You are evaluating an irritable 6-year-old girl with mottled color. On primary assessment, she is febrile with a temperature of 40 degrees Celsius or 104 degrees Fahrenheit. Her extremities are cold with a capillary refill of 5 seconds. Distal pulses are absent and central pulses are weak. Heart rate is 180 per minute, respiratory rate is 45 breaths per minute, and a systolic blood pressure is 98. Which of the following most accurately describes the categorization of this child's condition using the terminology taught in the PALS provider course? A. Hypotensive shock associated with inadequate tissue perfusion. B. Hypotensive shock associated with inadequate tissue perfusion and significant hypotension. C. Compensated shock requiring no intervention. D. Compensated shock associated with tachycardia and inadequate tissue perfusion. The correct answer is D. The systolic blood pressure is 98. Therefore, compensated shock associated with tachycardia and inadequate tissue perfusion is the best response. Number 21. An 8-year-old child was struck by a car. He arrives in the emergency department alert, anxious, and in respiratory distress. His cervical spine is immobilized, and he is receiving 100% oxygen by a non-rebreathing face mask. Primary assessment reveals a respiratory rate of 60 per minute, heart rate of 150, systolic blood pressure of 70, and an oxygen level of 84% on supplementary oxygen. Breath sounds are absent over the right chest, and the trachea is deviated to the left. He has weak central pulses and absent distal pulses. Which of the following is the most appropriate immediate intervention for this child? A. Perform endotracheal intubation and call for a stat chest X-ray. B. Provide bag mask ventilation and call for a stat chest X-ray. C. Establish IV access and administer a 20 ml per kilogram of normal saline fluid bolus. D. Perform needle decompression of the right chest and assist ventilation with a bag and mask if necessary. The correct answer is D. Perform needle decompression of the right chest and assist ventilation with a bag and mask if necessary. Number 22. An 18-month-old child presents with a 1-week history of cough and runny nose. You perform a general assessment, which reveals a toddler responsive only to painful stimulation with slow respirations and diffuse cyanosis. You begin a primary assessment and find that the child's respiratory rate has fallen from 65 breaths per minute to 10. Severe inspiratory intercostal retractions are present. The heart rate is 160, oxygen level is 65% on room air, and the capillary refill is less than 2 seconds. Which of the following is the most appropriate immediate treatment for this toddler? A. Establish vascular access and administer a 20 ml per kilogram bolus of isotonic crystalloid. B. Open the airway and provide positive pressure ventilation using 100% oxygen and a bag mask device. C. Administer 100% oxygen by face mask, establish vascular access, and obtain a stat chest X-ray. D. administer 100% oxygen by face mask, obtain an arterial blood gas, and establish vascular access. The correct answer is B. Open the airway and provide positive pressure ventilation using 100% oxygen and a bag mask device. Deliver one breath every 2 to 3 seconds. Number 23. You are supervising another healthcare provider who is inserting an intraosseous needle into an infant's tibia. Which of the following signs should you tell the provider is the best indication of successful insertion of a needle into the bone marrow cavity? A. Pulsatile blood flow will be present in the needle hub. B. Fluids can be administered freely without local soft tissue swelling. C. You are unable to aspirate any blood through the needle. D. Once inserted, the needle shaft of the needle moves easily in all directions within the bone. The correct answer is B. Fluids can be administered freely without local soft tissue swelling. Number 24. A pale and obtunded 3-year-old child with a history of diarrhea is brought to the hospital. Primary assessment reveals a respiratory rate of 45 breaths per minute with good breath sounds bilaterally. Heart rate is 150 beats per minute, systolic blood pressure is 90, and the oxygen level is 92% in room air. Capillary refill is 5 seconds and peripheral pulses are weak. After placing the child on a non-rebreathing face mask with 100% oxygen and obtaining vascular access, which of the following is the most appropriate immediate treatment for this child? A. Obtain a chest X-ray. B. Begin a maintenance crystalloid infusion. C. Administer a bolus of 20 ml per kilogram of isotonic crystalloid. D. Administer a dopamine infusion at 2 to 5 microgram per kilogram per minute. The correct answer is C. Administer a bolus of 20 ml per kilogram of isotonic crystalloid and monitor for signs of fluid overload. Number 25. You have just assisted with the elective endotracheal intubation of a child with respiratory failure and a perfusing rhythm. Which of the following provides the most reliable, prompt assessment of correct endotracheal tube placement in this child? A. Absence of audible breath sounds over the abdomen during positive pressure ventilation. B. Auscultation of breath sounds over the lateral chest bilaterally plus presence of mist in the endotracheal tube. C. Confirmation of appropriate oxygen and carbon dioxide tensions on arterial blood gas analysis. D. Clinical assessment of adequate bilateral breath sounds and chest expansion. The correct answer is D. Clinical assessment of adequate bilateral breath sounds and chest expansion. End-tidal waveform capnography and a chest X-ray are also used to confirm correct endotracheal tube placement.